So welcome everyone. For those of you that don't know me, I'm Suzanne Phillips. I'm the clinical lead for the cancer programme Norfolk and Waveney, and welcome to today's webinar. And the focus today is on breast cancer. We say kind of all things kind of breast kind of today. So we're delighted that first of all we'll start off with Dr. Hannah Rawlings talking about breast cancer. And if we were just those of you that maybe kind of caught the very beginning of our kind of conversation, we're talking. She does have a really helpful slide about anastrozole, particularly as I know we've had kind of lots of queries about it. And then that will be followed by the radiotherapy team at Norfolk and Norwich. So I'd like to kind of hand over to Dr. Hannah Rawlings, who's a breast physician at Norfolk and Norwich. She's going to talk a bit about breast cancer and in particular about treatments and side effects of treatments. And then she's going to chat a little bit about anastrozole at the end. So over to Hannah.
Thanks, Suzanne. Right. So hello, everyone. So this is what I thought we'd have a look at today. Just a little bit about breast cancer. The main issues that we see with patients, their concerns, what type of things we do to manage side effects in clinic, what people can be doing in primary care, and what we should be looking out for thinking about recurrence. And then there's a bit about what kind of support is available both from our side, but also what's available in the community. And then, as Suzanne said, we've been inundated with anastrozole queries, so there's a little bit of information about that and hopefully how we're going to manage that. And I'm very happy if people want to dive in with questions as we go along. So breast cancer, commonest female cancer, is the 4th commonest cause of death in women still as well. And for the average female, so no family history of breast cancer, then it's 1 in 7 women that will get breast cancer during their lifetime. And that obviously increases with age. It's much more common in postmenopausal. Commonest female cancer is the 4th commonest cause of death in women still as well. And for the average female, so no family history of breast cancer, then it's 1 in 7 women that will get breast cancer during their lifetime. And that obviously increases with age. It's much more common in postmenopausal women, unlike the hereditary ones where their incidence increases as well, but they usually start at a slightly younger age. We get about 700 cases a year as a unit, and on average we get about 5 men a year as well. And things are improving. So over the past 40 years, survival rates have doubled. Women who are diagnosed with breast cancer now, 85% of them can expect to still be alive in 5 years' time, which is good. Next one, thank you. So, and things have come on vastly in terms of how we treat people and what's been offered. So it used to be 20, 30 years ago, there was breast surgery, everybody had their axilla cleared, and then they did or didn't get chemotherapy, radiotherapy, tamoxifen, and it was fairly standard. And now there are many, many more options. So in terms of surgery now, it's usually either mastectomy or breast conserving surgery. And now there's reconstruction if people are having mastectomies, but there's other things like therapeutic mammoplasty. So if you've got a big cancer, but you don't need to do a full mastectomy, you can reshape the breast into a reconstructed breast. So I have some very clever techniques, some of my oncoplastic surgeons, colleagues here and in the plastic surgery department. The auxiliary procedures have got more refined as well. So we've had sentinel lymph nodes here for several years. So we use isotopes to recognise the first node in the axilla, and we just take that one out. So we do that when they've had an ultrasound scan and we don't expect to find anything in the armpit. There's now targeted axillary dissection as well. So if we think that there's just one node involved, then you can take that one out, but take a couple around it just to make sure it's all clear, and then still auxiliary clearance for people who've got an armpit full of nodes. Endocrine therapy is pretty similar, tamoxifen, and then the aromatase inhibitors. We also use Zoladex, particularly in younger women who we think might be more at high risk, and oncology treatments, which I'm not going to talk too much about because that's not my area, but lots of different chemo regimes now, and we are giving less chemotherapy and giving it more appropriately now. You will probably have seen in clinic letters people are having oncotype done. So that's a genomic panel that we send away a sample from the tumour, and it comes back and tells us what the benefit is going to be of chemotherapy. And so we're now only giving chemotherapy to women who score highly, who we think chemo is going to be beneficial for. And it's quite surprising. There are some cases where we historically would have given them chemo based on things like their tumour grade and the size, and we get a low oncotype score, and they're then avoiding chemo, and vice versa as well. And now there's a whole load of new targeted therapies, immunotherapies for breast cancer treatment as well. Radiotherapy, lots of new techniques. I'm not going to talk about radiotherapy because I know Lara's going to do that bit. And then bisphosphonates. So not bisphosphonates that we give alongside the aromatase inhibitors, but bisphosphonates that we give for women who are considered to be high risk of developing bone metastases. So they now get given oral ibandronate or 6 monthly IV infusions for 2 to 3 years after diagnosis. If women are under 40 and they are on tamoxifen and they're still getting menstrual bleeding, that suggests that their ovaries aren't being suppressed enough. So they're probably the group who we might be thinking about giving Zoladex alongside their endocrine therapy. And if you're unsure and you pick up somebody who is still bleeding, then you can always drop us a line and we'd have a look and see if we think they should be given Zoladex as well. Thanks. So these are all the different things that women worry about. A lot of them are side effects of the tablets or the treatment that they're having, but a lot of the tablets and treatment that we give will put people into menopause or worsens their menopausal symptoms. So things like putting on weight, loss of libido, vaginal atrophy, so they have difficulty with intimacy, they get Lutz syndrome. There's a lot of overlap between what is normal menopause and what is worsened by the treatment that we give, and so that can be quite hard to unpick. Fertility is a big one as well. We are seeing more young women, particularly women who have not yet had children, and so we now have a fertility pathway for women who've not had children yet as well. Okay, next, thanks. So endocrine therapy, there's 2 main groups that we use. So tamoxifen, which is a selective estrogen receptor modulator. So it inhibits estrogen from working on cells. So the way that it works, about 70% of breast cancers are ER positive. So they're the ones who will get it. And because it's lowering your estrogen, it gives you menopausal symptoms. It also has a small risk of endometrial cancers. So if you have 1,000 women on tamoxifen, then you'll get 3 extra cases of endometrial cancer. And thromboembolic events, so blood clots, DVTs, PEs, high risk of stroke, and there's around 10 extra cases per 1,000 women who are taking it. The tamoxifen works selectively, so it inhibits in the breast, but it has stimulatory effect in the endometrium. So that's why women get sort of vaginal discharge and the increased endometrial cancer risk. And then there's the aromatase inhibitors. So letrozole and anastrozole, which chemically are very similar. So if somebody has side effects with the letrozole, then we'd usually then swap them to exemestane because the side effect profile is going to be quite similar with the anastrozole. Again, that's mainly menopause symptoms, but also increased risk of osteoporosis. So as you guys will know, they have calcium, vitamin D supplements, possibly bisphosphonates, and have DEXA scanning usually as well. So treatment-wise, so everybody used to get given 5 years, that was standard. And then there were a couple of trials that came out and said, oh, what if we give people 10 years? And that has been shown to reduce the risk of recurrence, the risk of mortality from their breast cancer, and their overall mortality. But the study was done with tamoxifen. So initially we started extrapolating and saying, oh, we didn't have evidence for the aromatase inhibitors, but it would seem reasonable that they would have a similar effect. So we were either giving 10 of tamoxifen if they're young women, or if women had got 5 years of tamoxifen and we wanted them to have 10, they then gone on to an AI for the next 5 years. Or if they couldn't take tamoxifen, then we would give them an AI and we'd go up to 10, but allowing for their bone density. And sometimes that might mean we had to stop it early. There is now studies where there's support for using the AIs for 10 years. So where their bone density allows, then that's what we're doing. Again, if young women who are higher risk, who are still premenopausal, then if they're needing 10 years, then we sometimes would give them Zoladex to make them postmenopausal, and then we can give them an AI. The AIs have been shown to be slightly more effective in postmenopausal women. And the people who typically get 10 years are ones where we're more worried about recurrence. So if they've had an armpit full of nodes that were involved, if the tumours are very big, or if they're grade 3 tumours. Thank you. So managing side effects. So the first thing is, if someone comes to me in clinic and asks about their medication, is really looking at whether or not they need it, because there will be some women, if they've only had DCIS or they've had a very low risk, tiny grade 1 tumour and their armpit was all clear, is actually how much benefit are they getting from the endocrine therapy? And we use a tool called Predict, and we can input all of the tumour characteristics and patient characteristics, and it tells you what the overall benefit is. And if it's over 3%, then we'd usually say that would be worth giving. And then what we do is, if we think it's worth it, try switching between them. So instead, if they can, depending on what they can actually take, then if it's premenopausal, they haven't got much option. It's tamoxifen. If they are postmenopausal, then we would try out the range of tablets and see which one works for them. Vulval symptoms, really common. With tamoxifen tends to be more discharge as well as atrophy rather than dryness, which you get with the aromatase inhibitors. Lots of non-hormonal things that you can try first, which is what's preferred: coconut oil and massaging and stretching the vulval tissue. Haven't recommended it to my patients, but I've heard that you can buy little bullet vibrators, which are very good and have been shown to help with the vulval tissue there. So you put on the moisturizer and then use that to massage the tissue. And then there's moisturizers as well, like Replens, loads of lubricant for intercourse. And then we move on to hormonal things. So generally speaking, if someone's on tamoxifen, then we're quite happy for them to have vaginal estrogen, because it's going to be blocked by the tamoxifen anyway. If they are on an AI, we'd usually say you can use it, but try and use it for the shortest duration possible, and at the lowest dose. Now, when the tissue is atrophied and it's dry and you give them estrogen, then you tend to get a peak in estrogen levels. So it's better when the tissue is well estrogenized, then you get a more constant level, and the E string tends to be better because it tends to have a more constant effect. So these sort of go up in estrogen concentration. So Bliss L gel is very low dose, then in Vagus pessaries, which are a little bit stronger, and then Vagirix or Vagifem or whatever's being used now, and the E string. Venlafaxine has got very good evidence for hot flushes, also helps with sleep and mood. I've put in there, you guys will probably be aware, if you're prescribing tamoxifen, then there are some of the SSRIs it doesn't work well with, but venlafaxine is generally okay, as is sertraline. Oxybutynin has now got good evidence for helping with hot flushes, vulval atrophy, and the LUTs that are associated with vulval atrophy as well. CBT, good for flushes, and then there is insomnia-specific CBT as well. Acupuncture, I think locally the only place that provides that is Star Throwers. So if people are interested in acupuncturists, we would recommend they contact Star Throwers. And then, excitingly, there is a new drug which is on the horizon, which targets thermoregulation. So it doesn't interfere with estrogen or hormone levels, but that one looks like it will be a very good option for treating hot flushes in the future. I think that's next one, please. Okay, so we give general advice about living with breast cancer and life after breast cancer. So these are all the normal things that we advise about in clinic to help people keep an eye out for what they should be doing. So weight, so we make more estrogen in fatty tissue in the body. So particularly in postmenopausal women, if you put on additional fatty tissue postmenopause, that increases your breast cancer risk slightly. So it hasn't been shown to be in premenopausal, but it's mainly for postmenopausal women. Alcohol, we advise trying to stick to 7 units a week, exercise 2 to 3 hours a week, not just for breast cancer, but helps cut the risk of other solid tumours as well. Dietary wise, there is no one diet that's been proven to help with cancer recurrence, but there's a possibility that high fibre diets can help. And then regular self-examination. So if they're young women and they're still having a menstrual cycle, you try and get them to do it at the same time in the month, so they're not just feeling hormonal differences. And if they're postmenopausal, then again, roughly once a month. And we have a lot of ladies who understandably are very anxious about finding a recurrence. They're checking several times a day, and I think do themselves a disservice by doing it that frequently, because things happen very slowly. If you're checking every day, you're not going to notice if there's a small difference. If it's 2 or 4 weeks, you're more likely to notice a difference then. Next one, please. Thanks. So when to think about recurrence. So I've divided this up into what we look out for in the breast, and then what the other secondary symptoms are that you want to look at. So obviously in the breast or around the chest, if they've had mastectomies, then new lumps, lumpy bits, hardened tissue, thickening, anything like that. We also say check around your armpit for any lumps and in the neck. So a common site of recurrence is the FCF node, just here above the clavicle. So I tell them they should be checking that as well. Skin changes on the affected breast or over the chest wall. Lymphedema is really common. Not really common, it's about 5% after an axillary clearance, but it's a common thing to get without it being worrying. That said, it usually happens earlier on post-surgery. So we'd say if it happens within the first few months, then that's to be expected. If somebody gets to around a year and they then get new onset lymphedema on the same side as their cancer surgery, then we should be seeing those people back in clinic to exclude axillary recurrence. And secondary symptoms, so headaches. So you've got a lot of HER2 in your brain. So if people have had HER2 positive breast cancers, they're more likely to develop brain mets or triple negative tumours simply by the virtue that they're more aggressive. So headaches, any signs of raised intracranial pressure like nausea and vomiting, visual disturbance. Persistent bony pain, the main sites that we get bone metastases, back, femur, around the ribs. So any persistent area of discomfort, then we would see and scan. Back pain, particularly if it's associated with sensory disturbance or bladder bowel dysfunction, that might suggest you've got a MET pressing on your cord. Unexplained weight loss or loss of appetite, significant fatigue. It's very tricky because a lot of this can be side effects from their medication as well. So often what we'll do is say, have a break for 3 or 4 weeks from your medication and see if things get much better or not. If you've got bone lesions, then that can leach calcium out into your bloodstream. So any symptoms of hypercalcemia, you can get pleural effusions, lung nodules, so persistent coughs or shortness of breath we're interested in as well. And abdominal symptoms, so particularly lobular breast cancers often recur around the abdomen. So bloating, discomfort, feeling full early, then they're all things that we should be looking at. Next, please. So this is currently our pathway for following up patients with curative intent. So when they come at their diagnosis, they're generally allocated a breast care nurse, and we try to ensure that that breast care nurse is the one who's with them for all of their subsequent appointments. If they're seeing oncology, then they'll usually have a cancer nurse specialist from the oncological side as well. The breast care nurses usually do a holistic needs assessment at the start of treatment, see what the patient's concerns, financial, spiritual, emotional, their feelings about the effect on their family, and anything that we might not sort of cover in the clinical side. When the emphasis now, so we used to do, we'd see them at years 1, we'd see them at year 3, and we'd see them at year 5. And nationally, we've moved away from that now, and the emphasis is much more on supporting patients post-diagnosis to manage their own breast cancer. So there's a survivorship clinic which is done at around 6 months or whenever their oncology treatment has finished, and that's the breast care nurses who see them then. And then at 1 year, they then come back and see one of us in clinic. We examine them, we arrange them their mammograms, because they'll usually be getting extra screening, check that their medication is okay, or whether or not we need to do any changes. And they're then discharged onto this PIFU, or patient-initiated follow-up pathway. So they're basically under us for 5 years following the diagnosis, but there's no scheduled reviews with us. We talk through all of the symptoms and things that they should be watching out for. They get given information packs. And then if they've got concerns during that time, they then contact the breast care nurses. And they will then put them into clinic if we need to see one of them. And not everybody goes onto this. Occasionally we make an exception because there might be people with learning difficulties who can't manage their breast cancer themselves, or if people are incredibly anxious, particularly around risk of recurrence, and we know they're just not going to manage self-checking, then occasionally we will keep some people on in clinic until we feel that they're able to manage it well themselves. I think we've had a lot of good feedback. It's very positive. There were a lot of people who found coming up to hospital every year for checks stressful. It doesn't usually result in any earlier diagnosis. I think of all the people who we would check every year. I would like to say I never personally picked up a recurrence in a clinic appointment. It's usually all on the mammograms or the patients noticing things themselves. So I don't think that doing it this way there's no missed opportunities doing it this way. Next, please. So the support that we have available here, obviously we have our breast team, doctors and specialists, and we're very lucky that we've recently had a psychologist join us. We did used to have one, and we've been without one for a couple of years. So this is really fantastic for us. And usually it's not one that she can't be referred to from primary care, so they'd have to be referred to us first, and we would then arrange it. But the patients, if they felt it was useful, they could probably get in contact with their breast care nurses who could then make the referral. There's a prosthetics service, a lymphedema service that we can refer to, which is based in the community. We have links to plastic surgery for reconstruction, and then for our young women who haven't yet had families, then we have a pathway to refer for fertility treatment over at Bourne Hall. We have genetic counselling, so that's either seeing myself or one of my colleagues in clinic, or if it's more complex, then we will refer to Adam Brooks, where the genetic testing is carried out. We are hoping to get a menopause service. We used to have one of my colleagues who ran one, but we have got a menopause specialist who's interested in working with us, which would be wonderful, because there is a huge need to support these women post breast cancer with their menopause symptoms, which I don't think we're doing particularly well at the moment. Next one, please. And then these are a list of all of the external, mostly charities that we use or recommend. So Macmillan, Star Throwers, Big C, we think you will probably all have come across, and Wellbeing. Little Lifts is a recent charity that's been set up, and people get given a little box full of goodies, and then they're supported after that. Keeping Abreast is a support group that was set up by one of the plastics reconstruction nurses, which has brilliant information about what people can expect when they're having surgery and reconstruction. There is a specific support group for young women who are having breast cancer who might face slightly different issues to women who are having it later on in life. The HOPE course is not breast cancer specific. I understand that one's all cancers, but is another option. And then we recently had a talk from this lady who runs the Cancer Hair Care charity, and it was very impressive. So if you've got any patients, you're not just breast cancer, but anybody who's got issues with their hair after having chemotherapy, anything like that, then they can just get in contact with them. It's a free service. Next one, please. Okay, so I think that's everything I wanted to say about managing breast cancer in our clinics. I was just going to mention this because I'm sure you guys have been inundated as well. Obviously, it came out in the news last month in anastrozole helping to reduce breast cancer risk, and the stats that they quote are quite bombastic. I think 50% risk reduction. It's not new. The NICE recommendations came out in 2017, but it's just that anastrozole now got a license, so it's been in the press. So chemoprevention can be used to reduce the risk of developing breast cancer in women who are at moderate or high risk of developing breast cancer. You can use it in women who are at very high risk, which is usually gene carriers, but mostly for BRCA2 and PALB2. We don't tend to give it BRCA1 carriers because they have a higher risk of developing ER-negative breast cancer. So usually these women need to have been seen either by us or genetics and know what their risk level is to see if they're eligible. We start from age 35 and there isn't a limit on how old you can give it to. It starts at 35 because that's what most of the studies did, and also because it's very rare to get breast cancer in women under 35, so the benefit starting it younger is going to be much less. They take a tablet daily for 5 years, so it's quite a commitment. A lot of women do stop it early or don't start it at all. So it's tamoxifen in premenopausal women, or if they're postmenopausal, they can use tamoxifen. They can also use anastrozole or raloxifene. The benefit is very variable. The lower your overall risk, the less benefit you're going to derive from taking one of these, whereas the higher your risk, the more benefit there might be. So for tamoxifen, I think you have to take, the number needed to treat is 58. 58 women have to take it for 5 years to prevent a breast cancer. And for anastrozole, it's 29. So it's not for everybody. It's a reasonable choice for women who are at risk, but as we've already seen, there are considerable side effects. Yeah, we have a chat with them. What we're doing at the moment is that if people are referring to us, we're then booking a family history appointment to make sure that we know accurately what their risk level is, and then discussing with them using it, sending them one of our information sheets, and then if they want to go ahead, then asking the GP to prescribe it for them. If we've got people who are obviously under our family history clinic already, and we're going to send them out a leaflet with all the written information so that they could, again, ask about it if they want to. The risks are the same, as discussed when we talked about the breast cancer. But I think we struggle to keep patients taking these tablets when they're taking it post breast cancer. I think it's a struggle to persuade people to take these when they haven't got breast cancer, and it's just to reduce their risk. And the vast majority of people I've spoken to already really just want validation that they're not being stupid by not taking up the option, and are usually quite happy not to take it once we've had a discussion about the risks and the side effects. I think that's everything. Oh, one last point. So I was going to say the chemoprevention, although it can reduce your breast cancer risk, it makes no difference to breast cancer mortality, which is a big point when you let patients know that. That's usually the nail in the coffin for them deciding not to take it. That's it.
So thank you very much, Hannah, for a really, really interesting kind of talk. Before we kind of open up to kind of other questions, I just had a question just to kind of clarify. So in terms of the chemo prevention, who is it that you do want to see in clinic to discuss it? So who should GPs or anyone who's seen kind of patients refer to you then?
I think so. I mean, if they're under us already, then we're just going to send them a leaflet saying you'd be eligible for this. I think we probably need some interaction with primary care, because from what I understand at the moment, it's a bit vague, and GPs might have been told that it's a secondary care initiation and then possibly GP prescribing, and that could take the form of advice and guidance. So if they're under us already, we're just going to send them a leaflet and say it's an option, and they can go and ask for it. If the GP thinks that they have got a significant family history, then refer to us and we'll have a look. The people who are not going to benefit, anybody under 35, because we don't start it in women under than that, can't take it if you're pregnant, breastfeeding, or if you've got contraindications, which would mean you can't actually take any of the medications. And women who are older are not going to have a significant benefit. So I spoke to someone last week at 79 and said I didn't think it was in her interest to take it at 79, because you're talking about preventing cancers, years later, when life expectancy may not be that much anyway. Yeah, that answers the question.
Yeah, great. So basically, if they're kind of felt to be high risk, you're happy to see them. Is that kind of?
Yeah, I think. Yeah, I'm very happy either that we need, and if people aren't sure, then just advice and guidance, or an email, and we can decide whether or not we need to see them in clinic or not. The more information you put on the referral about their family history, the better, because it makes my job a lot easier to assess whether or not they're actually at any risk.
Okay, that's great. That's really helpful. And Sue just put in the chat box, actually, I think another kind of support group. Is that right, Sue, that you've just put in there?
Sorry. Yeah. Treasure Chest, Hannah's really good.
Obviously,
okay. I've met up with her, and yeah, she's a really good support for breast cancer
Treasure Chest
as well. Yeah, I've put the link in.
Okay, fab. Thank you.
I was just going to ask a question. Actually, you said your survivorship clinic. Mm-hmm. So can the patients just can they just get into that, or would they be put into that, or?
So the one at 6 months.
Yeah.
They're just put into it. It's just standard follow-up. It is currently. We are looking at stratifying patients. So if they've had very low risk, just DCIS, they've not on any tablets, they've not had chemo or anything, they may not benefit from a big appointment going through all of their concerns and stuff. So at some point in the future, we're likely to stratify who we're seeing. But no, at the moment, everybody will be offered one when they're either 6 months or finish their oncology treatment.
Lovely. Okay. Thank you. Yeah, maybe I'll catch up with you, Hannah, because obviously I'm doing case studies. I'm Sue Tro here from the Cancer Transformation team. Mm-hmm. And I'm doing case studies for patients, and I've recently talked to a breast cancer patient, and she's getting the support, I think, off of a breast care nurse, but she has really felt recently, quite needs that psychological help.
Okay.
So maybe I could catch up with you.
Yeah, that's fine. Ping me an email.
Yeah. Okay. Thank you.
Thanks very much, kind of, Sue. And you're mentioning actually that patients now aren't followed up, obviously, in the routine kind of way on a regular basis. Have you had any feedback about that? How do patients view that?
Mixed, generally positive. There's a lot of, oh, thank God I don't have to come up and see people. I think it's different depending on the patient group. So because they're still coming for screening and they're having their mammograms every year, it's okay. They're still being monitored. Those women who have had mastectomies and won't be getting any breast screening, it's a bit of a void. We discharge them then at 1 year and say, "Oh, come back if you feel anything," but there's no contact with us otherwise. Generally, I think it's been well received. As long as that's what patient expectation is at the beginning, it's been fine. It's been more tricky converting the ones who were used to being seen every year or two and telling them we're not going to be seeing you anymore. But I think we're largely through that now, because it's been brought in over the last 4 years. So I think we're now on to just people who will be on the new follow-up.
Great. No, thank you. Just kind of conscious of time.
Yeah,
any other
sorry,
questions? No, not you. Just thinking if we didn't have any other questions, probably need to kind of move on. But any other questions for Hannah? No, well, thank you so much. It was a really, really interesting talk. And as I say, for those of you who haven't been able to join, we'll be sharing the slides after this session. So thank you.
Thanks.
So now I'd like to introduce Lara Anthony, who works in kind of radiotherapy at North Norwich, and also she's got her colleague Mark Gillam as well, who's head of radiotherapy, who's not going to do the talk. It's just going to be over to kind of Lara. Is that right? Today. So if I pass over to kind of Laura, who's going to talk about radiotherapy, some of the kind of side effects, and also about a new clinic that's been set up. So I'll hand over to Lara.
Hi, thank you. Firstly, thank you for allowing me to present today, and hopefully by the end of the presentation you'll know a little bit more about our service. So I'm Lara, I'm a therapeutic radiographer, and I've been working at the North Norwich for the last 16 years. Earlier this year I was successful to get the role as a late effects lead for late effects service here. This is a pilot service and it's funded by Cancer Alliance. The aim is to be able to evidence its worth and roll it out to all departments within the east of England. The service went live in October, and patients have started to come in through people who are aware of the service, and hopefully at the end of this you'll be aware of the service too. And I just hope that by the end of this presentation you'll have a clear understanding on possible late effects and who the service is for and how to refer them in. Next slide, please. So a slight recap on radiotherapy. Obviously, as you're aware, radiotherapy is a common cancer treatment. Radiotherapy causes toxicity via damage to cells. Acute toxicity happens while a patient is on treatment, and they should improve within a number of weeks. Late toxicity or late effects appear months or even years later. Both of these types of toxicity will depend on the area that the patient was treated. All side effects are localized to the treatment area. So if someone's eye is watering but they had their pelvis treated, it was not to do with their radiotherapy, even if they think it was. The severity of the side effects can be impacted by many things listed here. I will also discuss later on the importance of prehab, a little bit like Hannah did, and just the importance of helping patients at every part of the pathway. And as a side note, I will add that acute toxicity is monitored and reviewed weekly while the patient is on treatment by a dedicated team of review radiographers. That's my background, that's what I've been doing for the last 8 years, but I'm aware patients don't always acknowledge that they're being reviewed. Next slide, please. Before I talk about the clinic itself, I want to empower people working in primary care, not to try sound pompous, but that there is support out there for primary care to manage late effects. Macmillan have lots of useful information, and that this service is not to take away from the impact primary care has on these patients, because I know that a lot of management is done by primary care, but it's just to help and support it. As you're probably aware, it's predicted that over 3 million people will be living with and beyond cancer by 2030, and there's evidence to suggest that these patients have unmet needs and struggle with the impact cancer treatment has had on them. As the number of people living with cancer rises, so does the challenge of managing their effects and to improve their quality of life. The nature of cancer treatment means that subsequent consequences vary significantly between patients in frequency, timing, severity, and the impact of their quality of life. The level of nature and support that patients will require will therefore vary significantly. Next slide, please. So as I said earlier, this is a new service that is being run at the Norfolk and Norwich, and it's a pilot funded by Cancer Alliance for 2 years. Almost half of cancer patients receive radiotherapy, and as I said, the early and acute side effects, they're normally characterised biologically by inflammation and edema, and they should resolve within weeks. Late effects are characterised by fibrosis and develop months or even years after the treatment. Late effects, the term late effects also covers long-term effects, whereby an acute toxicity has not improved after 6 months following treatment. Patients are informed about late effects at new patient clinics, and recently the RCR consent forms have been improved to include late effects and possible late effects. So patients should be aware what they're signing up to. Late effects are difficult to diagnose. Management is often complex, and often there is no actual fix. It's important to add that this is a radiotherapy clinic, but side effects from other treatment modalities aren't ignored. So, for example, chemo, often patients are left with peripheral neuropathy, and they might have pain following surgery. Immunotherapy, hormonal treatment, they all give side effects, but this is a radiotherapy main clinic. But it is hoped that in the future we can have a bit more of an MDT approach. Yeah. Next slide, please. Thank you. So who is the service for? I've included the inclusion and exclusion criteria from our referral form, but fundamentally the service is for anyone who has an issue that affects their quality of life following radiotherapy. As an example, if you have a patient who has rectal bleeding, obviously recurrence does need to be ruled out as the first line, and I would assume they would be referred for, say, a flexi-sig. Often results will come back clear, no recurrence or any other problems, but they might be diagnosed as radiation proctitis. And management of radiation proctitis is normally just to leave it, just manage it. But that patient still had a problem, and that's where the service can come in, even though it might be that there's nothing that we can necessarily do. But I can go through treatment plans with them to show them why these symptoms are happening, why they're having this reaction. I can explain what fibrosis is. I can give them some self-management techniques. I can suggest medications if required, and I can put them in touch with local charities or support networks. I do a full review so I can hopefully improve their quality of life. Next slide, please. Oh yeah, for anyone. This is our referral form. It's in the process of being put through to primary care. Fundamentally, the most important thing we need to know is what their symptoms are of the late effects, and then I will vet them and bring them in for an appointment. I will say at the moment, if anyone needs anything, please feel free to email this email address. Thank you. So what will the patient experience from the late effects? First, this service is a patient-centered service, and it aims to provide a full holistic approach. The process starts with them filling out PROMs, and that's to find out what the problems the patients are dealing with, but also to find out what their actual problem is, because sometimes a physical effect may be written down, but actually it's not necessarily that's affecting them, and it's something different. So hopefully I can get a real understanding of that patient and their problem. The clinic aims to be a one-stop shop. So as I said earlier, the different ways in which we can help can just sometimes be reassurance, it can be self-management techniques, it can be medications, it can be onward referrals to the relevant departments within the trust, and I can put them in contact with local charities and support networks. Currently, I'm not a prescriber, but I can make recommendations based on national guidelines. And at follow-up, I will assess how the management techniques have been and hopefully discharge them or organise further follow-up if needed for that patient. Next slide, please. So I thought I'd spend some time going through the late effects, like the most common ones. These include physical and psychological, and again stressing the point that the side effects are related to the area that patient had treated. So as you can see from this picture, there are many effects from radiotherapy to the pelvis when patients have had radiotherapy to the pelvis. Bowel and bladder are the most common, so that can be frequency, urgency, incontinence, bleeding. Bowel effects are classified as pelvic radiation disease, and Pelvic Radiation Disease Association has created a guidance booklet, and I don't know if you're aware of it, but it's fantastic. It walks you through the problem, what investigations should be required in order of importance, and potential results, and then a clinical management plan of those results. as I said earlier, sometimes patients just need reassurance, and sometimes support can come from a radar key or a toilet card, which can help. And these can be accessed by charities that I've listed at the end. Sexual dysfunction after pelvic radiotherapy is really common, and it's something that patients aren't always willing to talk about. I'm not sure if you're aware, but all female patients who have radiation to their pelvis, whether it be gynae or bowel, are due to get vaginal dilators. So we give them dilators because they can get vaginal atrophy, and a third of patients may develop vaginal stenosis. With the dilators, we encourage them to use them 3 times a week for the rest of their lives, but obviously it doesn't always happen. And radiotherapy to the pelvis for men can contribute to erectile dysfunction. And all of these effects will affect their quality of life and have a psychological impact on them. Next one, please. As you can see here, head and neck radiotherapy can cause lots of toxicity that is very difficult to manage, and it will again really impact on their quality of life. I've written a list, started a list of lots of physical side effects, and it doesn't even include the psychological impact. But for example, a patient might have a dry mouth, and they might manage eating and drinking okay because they organise techniques and, drinking plenty of water while they're trying to eat, cutting food up really small. But it can affect their quality of life by their inability to kiss their partner due to lack of saliva, or their lack of drive to be intimate due to fear of bad breath, for example. And it's really important to try and holistically look after the patient. I will add that head and neck patients are really well looked after during their follow-up appointments, and they're seen by the dietitians and speech and language therapists routinely. Thank you. I've combined chest, breast, esophagus patient side effects together here. And in regards to radiation to the chest, these are the most common side effects, and they often can affect the lung and the heart health. The importance of radiotherapy techniques changing with time is helping us to improve these late effects, and it's another reason why we're implementing this clinic, because in order to assess what side effects people are being left with, we can then improve our treatment techniques and our planning techniques to improve the side effects that might happen, and make our borders smaller so that we're not giving so much dose and so much toxicity. Next one, please. A small section just about endocrine, just because the importance of it. The endocrine glands are really sensitive to radiation, and patients who have radiotherapy to the head and neck should have an annual thyroid function test. For example, whole brain radiotherapy can lead to pituitary failure. I will say, if a patient was sent to me, I would refer them to endocrinology. So I would encourage you to do that one as a first referral, but likewise, I'm happy to see the patients who are dealing with this as well. Next slide, please. The only late effect, red flag, I suppose, that needs urgent attention really is lymphedema. As you might be aware, we have a fantastic service based in Bowthorpe, which I believe covers the whole of Norfolk and Waveney. But any patient with lymphedema should ideally be identified immediately post-treatment and can be referred in via this email address on here. Next one, please. In addition to the late effects service, as I said earlier, I just want to introduce this slide, which shows the importance of prehab in cancer care. Prehabilitation and getting ready for cancer treatment in whatever time a patient has before their treatment starts has been shown to be really important. Ideally, a program of support and advice on the following things would be beneficial. So that's diet and exercise, and mental well-being, smoking cessation, and cutting down on alcohol intake will help. It helps with the patient while they're having treatment, it helps with recovery, and it's important with their overall health. As you can see, it can make their baseline better than it was before treatment. Thank you. We currently don't have an active prehab service for patients in Norfolk, not all patients. It is something that is being looked into to being developed. However, any person that comes into contact with a cancer patient can have a positive impact on them by encouraging those techniques of talking about diet, exercise, and mental health, whatever. It can really help them to have a healthy lifestyle and increase their quality of life. Again, Macmillan has tips on how to support that. Next one, please. Again, we have a lot of support from the local charities. The first three, so the Big C, Macmillan and Starthrowes are the ones that I refer to the most, but these are some of the ones that we've referred patients to, whether it be for physical side effect advice or just putting them in contact with other people that are dealing with the same thing so they don't feel like they're alone. Thank you. That's just my references. And then finally, any questions? Thank you very much.
Thank you very much, Laura, for a really interesting talk, particularly running through all different side effects of kind of radiotherapy. And I know we've met before and we discussed the service, but I think it's kind of much needed. And certainly I say my background's a kind of GP, and so it's really nice to know that there's somewhere actually to kind of refer the patients to, because often we are at a loss to kind of what to do with them. So thank you. Any questions for Laura at all? And so we've got just a comment in the chat box from Kate, who's just mentioned again, in fact, mentioned Tracer Chess, but also she was mentioning Flat Friends. Are you familiar with them? And Sports Action for Women as well, that might be of interest to kind of support groups for kind of women.
Thank you. Yeah, I haven't heard of those ones, so I will let our breast care nurses know about them.
Me neither, actually. Kind of Kate, actually, kind of Flat Friends. I haven't heard of Flat Friends. I've heard of Treasure Chest, but not Flat Friends. I don't know if Kate can elaborate. Kate, are you there? No. Is that for charity?
Sorry,
or
my team's decided to freeze at the best moment. So they are a national charity. But they've got a lot of resources on their website. They do meetups as well. They've got, like I said, quite a lot of resources. They do online forums and stuff like that. So it's just sort of something, again, to kind of have in the, the back burner. If someone doesn't necessarily want to go to groups, it might just be they can go to that website for information.
Great. No, lovely. Thank you. Marika, you've got your hand up.
Yes, I was just going to speak about the referral form, because I know we've been working with you, Lara, on trying to confirm that and for it to go through the necessary governance processes. So it may take a bit of time for that to become available, isn't that right?
Yeah, but in terms of if anyone has any questions, please do email me.
And I think we did say, didn't we, kind of, Laura, that potentially actually if there is someone, if there is anyone that someone particularly wants to refer, then you'd be happy if they kind of contacted you and kind of accept the referral, even if it's not via the referral form. Is that right? Yeah.
Feel free to email me if you've got any patients that spring to mind that could benefit, and I can sort something out.
Lovely, thank you.
I think the important thing is just to rule out recurrence before they come in, because that's the one thing that we would worry about referrals coming in, that they have to have had that recurrence ruled out first.
Yeah, no, absolutely. I think when we were talking before, weren't we, like with rectal bleeding, actually you would want to make sure that you haven't got a kind of cancer kind of sitting there, a kind of secondary kind of cancer sitting there before they kind of refer. So no, thank you. Any other questions at all? Well, thank you very much, all of you, for kind of speaking today. Really, really interesting talks. And same, we'll be sending around the slides, and also the point of view where is that we actually send the recordings of these, and we do know that people do look at it afterwards. So we actually have had feedback that people really do that. We have got our next kind of webinar in January, which I'm afraid we can't say what the title is, because the person that was going to speak is now unable to speak. So we're kind of frantically kind of seeing if we can kind of move things around, and someone who was going to speak kind of later in the year kind of speak kind of in January. So we'll let you know what that is. But also just a bit of a kind of a plug. And as you see, breast is kind of sitting there. In fact, not any of you you are going to come and speak, but we're hoping kind of we're kind of sharing it around amongst the trust, hoping someone from one of the other trusts is going to come to talk about kind of breast pain. So just to say, we have got an educational event that we're planning. It's going to be an in-person event at the end of February, and the focus in the morning is going to be around kind of general kind of cancer updates. We thought we'd add in a little bit of genomics there, because obviously I know obviously you were talking about obviously some of the genomic stuff that's happening kind of within kind of breast cancer, but also just generally how it's affecting our kind of cancer pathways. So we've got people going to come from the kind of genomics kind of team, and also kind of looking at the changes that are happening within kind of gynecology and also colorectal. And then our afternoon is going to be focused on kind of dermatology, and hopefully some kind of hands-on kind of training around kind of dermatoscopes. But we're just kind of finalising the programme, but we're going to send around to kind of just save the date for everyone. So thank you all kind of again. We're kind of finished just a little bit before time, and I hope everyone has a good afternoon and has a good Christmas.
Thank you.
Thank you.
Thank you, Suzanne. Bye, everyone.
Thanks. Bye.